Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer your questions from chapter's members about the COVID-19 pandemic and pretty much anything else infectious disease or infection prevention out there. This is the week of May 24th. The year 2023, and we again have some interesting questions. There's been all sorts of fun noise from the media about some drug resistance out there. In fact, a lot of our questions have to do with that today. The first one comes from a recent alert released by the CDC titled Multi-Drug Resistant Pseudomonas aeruginosa Infections Among U.S. Patients Linked to Healthcare Exposure in Mexico. So this actually has been an ongoing issue, and it's specific to Pseudomonas aeruginosa infections that are resistant to the carbapenems, that meaning meropenem, imipenem, ertapenem, doripenem, basically are huge guns that we all turn to treat that ultimately almost not treatable infection. So this is definitely a big deal. This is cause for concern. Fortunately, or I guess unfortunately, the cases that are being described are related to a specific type of medical tourism in Mexico, that being bariatric surgery. And the initial reports surfaced in actually 2018-2019 from two surgery centers in Tijuana, Mexico. There continue to be intermittent reports of those throughout other surgery centers in Mexico, but this is largely not an issue affecting pediatrics, mostly because it is typically not our pediatric patients going across the border for bariatric surgical procedures. On the other hand, that can happen. I have certainly managed several patients who had sort of repositioning of fat cells or fatty tissues from abdomen to buttocks and to breast, and have had localized infections due to that. So there is the potential that we may see pediatric cases, and that was what the questioner is asking. How serious are the infections, and what are the potential risks and complications? So the seriousness of a multi-drug resistant organism causing a surgical site infection can be actually quite significant. Frequently, if one has no valid antibiotic options to treat the sort of untreatable surgical site infection, then there's really not much one can do other than do progressively aggressive surgical resection or excision of the infected body parts. Unfortunately, especially with bariatric surgery, this would be a significant portion of potentially the abdominal wall and huge potential to enter into enteric sepsis with multi-organ failure, septic shock, and death. So I think that potential risk of these infections, if they're untreatable, is incredibly severe. That said, there are other antibiotics out there, even for those Pseudomonas aeruginosa infections that are ertapenem or carbapenem resistant. The newest cephalosporins, for example, ceftaroline is one example, do have still some preserved efficacy in some cases, and there are other options as well. The challenge is increasing the severity of the infection, and the decreasing effectiveness of the antibiotic means we have to use antibiotic options that have increasing rates of adverse drug effects. So, for example, one potential intervention would be with the drug colistin, which is a porin or a channel producer. Basically, it's the effect of glorified detergent, if you will, and carries a 50% risk of renal insufficiency, kidney failure, etc. So, should a patient have this infection, it is a big deal. As noted before, however, the overall risk of something like this happening in the pediatric population is quite low, and really limited so far to those patients either who travel across the border to have a surgical procedure, a bariatric surgical procedure, or those who are coming to us as Mexican nationals having had such a procedure. So overall, knock on wood, we've not yet had something like that in Arizona to my knowledge, certainly not that I've treated, but the risk is there, it's just very tiny. All right, next question. We have seen increasing rates of syphilis and gonorrhea in our practice. Yes, sorry, as to have, I'm sure, many of the listening audience, and certainly we have in the hospitals. The questioner goes on to ask, the syphilis and gonorrhea are becoming increasingly resistant to antibiotics. How will this impact our approach to treating such patients, and what do we see as the future of sexually transmitted infection treatment? So where are we at? What are the actual resistance patterns so far? For syphilis, thankfully, penicillin and doxycycline remain preserved as highly effective antibiotic options. So penicillin, so far, no resistance reported to penicillin, certainly in North America and even in the world. The challenge, of course, is not all patients can tolerate penicillin if they have a drug allergy. Those patients then should be treated with doxycycline, and there are only sporadic reports of treatment failure in patients on doxycycline, which actually more likely than not are related to drug adherence rather than true in vitro drug resistance of Treponema pallidum, the cause of syphilis. So far, penicillin and doxycycline are preserved. However, another alternate being the macrolide antibiotics, and specifically azithromycin, or for those who are real gluttons for punishment, erythromycin, there has been up to 15% reported resistance among Treponema pallidum, syphilis, to azithromycin. So there is that as a possibility. Gonorrhea, Neisseria gonorrhea, or the gonococcus, depending on which term you like to use, is a bit more concerning because there are case reports of isolates of gonorrhea which are resistant, or I should say decreased susceptibility. So not fully resistant, but sort of decreased susceptibility to ceftriaxone. The initial reports, and this is not going back even a decade or so ago, came to us from the country of India. In fact, that entire continent started to experience cephalosporin-resistant isolates of gonorrhea. And we have now had 2 cases reported to us from the United States, specifically in Massachusetts. That means there are others, and of course it was only a matter of time that gonorrhea could be imported through international travel into this country. However, the risk remains very, very, very low. So for our current purposes, ceftriaxone is still the go-to antibiotic for use of a patient with proven or suspected gonorrhea. However, if there is an apparent treatment failure, and here again is getting into recommendations about how to treat patients, we do need to do a post-treatment evaluation, certainly clinical, if there are symptoms, make sure symptoms has resolved, and even then to do a post-treatment testing, typically urine probe for GC, and confirm that our treatment was successful. If there is persistence of gonorrhea after an appropriate dose of ceftriaxone, or even oral ceftonir, which would be an oral version, related possible treatment, then we need to report that to the CDC, and there's a reporting form. If you'd like an example of that form, you can certainly go to cdc.gov, and a little bit closer to home, in California, the California Health Department also is very actively tracking the potential resistance emergence of gonorrhea, and there's a website there as well, which you can search through just a regular Google search. So to the question then, how will this impact approach to treatment? Still, current approaches is valid. So ceftriaxone, IV, IM, or ceftonir are our options, but we do need to be considering a post-treatment assessment to make sure a patient has cleared their infection. The longer future of sexually transmitted infectious disease treatment, I think we need to anticipate that emerging resistance will continue, and at some point in time we may lose the cephalosporins as a treatment for gonorrhea specifically. It is not likely that we will lose penicillin as a treatment of spirochetal infections such as Treponema pallidum for syphilis, only because that organism so far is very slow to mutate and has not shown the ability to mutate to become resistant to penicillins or the tetracyclines, meaning doxycycline. So I think long-term view, we can anticipate some further emerging resistance with gonorrhea, not so much with syphilis. And regardless of those, CDC is actively tracking all of these as possible emergence of resistance, and it gets then into the long-term support, that's a complicated word, but support at the federal level and the world level for new drug discovery. And that then gets us into the whole concern of antibiotic stewardship and antibiotic resistance patterns. Many pharmaceutical companies appropriately have realized there's not much money to be made in new antibiotic discovery, especially because new drugs will be used for a very tiny subset of patient populations for, in some cases, orphan diseases. As, however, we move into further resistance patterns, then hopefully that balance will shift in favor of federal support for pharmaceutical drug discovery, for antibiotic development, and then testing against our sexually transmitted infectious diseases. That is, we're talking not just the next year or so, we're talking honestly over the next 10 to 15 years. And certainly the CDC and also the national infectious disease organizations are lobbying actively for ongoing drug discovery, federal funding support, et cetera, and so forth. And as we emerge on the back end of the public health emergency declared for COVID-19 pandemic, it may be that there can now be attention paid back to the original threats, which have been there all along and didn't go anywhere. They were just hiding behind the skirts of SARS coronavirus 2. So we can now hopefully get back to lobbying once again for new antibiotic discovery, ongoing vaccine discovery, etc., and so forth. Okay, enough on that subject. Next one, New York reported the first ever treatment-resistant case of ringworm infection in the United States. Is this cause for concern? We can all get over our little itchies and scratchies now just thinking of ringworm and lice and scabies and all those fun, fabulous things. So indeed, this is not new news worldwide. In fact, even, again, 10, 15 years ago, treatment-resistant isolates of trichophyton, as well as tinnias, have been reported in India, and it was only a matter of time before those again would become stateside, and that has now been reported in New York. So specifically, our go-to drug for systemic treatment of ringworm, and that being currently terbinafine. It used to be griseofulvin. For those of us who are sort of my time of clinical treatment, remember the griseofulvin days and all of the liver testing and all those fun, fabulous things. Terbinafine is the current systemic drug, oral drug, to use against tinea corporis, tinea capitis, so ringworm of the body, ringworm of the head, and actually increasingly treatment-resistant jock itch, tinea cruris, and athlete's foot, tinea pedis. So there are always going to be those apparent treatment-resistant tinea which have been treated topically. The next step, of course, would then be to escalate to systemic treatment with terbinafine. New York finding a terbinafine-resistant isolate of tinea corporis, so body tinea, body ringworm, is of course cause for concern, but it's still a first reported case and not something which is a common concern whatsoever. So certainly no need to change our current practices, business as usual, and as noted for the preceding topic of sexually transmitted infectious disease, CDC is tracking this and again evaluating for need for additional antifungals, anti-tinea treatments if and or when further resistant ringworm develops in this country. So right now it's a unpleasant discovery, but not so much more significant than that at the time. And then the final question we have is regarding CDC talking about a possible monkeypox resurgence this summer. What are my predictions on monkeypox trends that we might see in the upcoming year? So just a brief backstory on why CDC is predicting a possible resurgence. I think we are all hopefully still aware that we just came through a cluster of monkeypox infections, primarily among men who identify as having sex with other men, transgendered men, etc., and so forth. So a fairly focused subgroup of our population that identify within the LGBTQR population. And that outbreak of monkeypox did have some pediatric cases, typically infants who are living in families in which an adult male who had monkeypox was residing, either as a primary care provider of that infant or somebody living in the house. And also, you will not be surprised to know or to hear that there were absolutely ethnic and racial disparities in those individuals who both acquired monkeypox, transmitted monkeypox to babies, and unfortunately experienced fatalities from monkeypox. It was very largely the black male having sex with other men population that were adversely affected primarily, and including the very few pediatric, mainly infant cases that were reported countrywide. So could this come back? And again, major kudos to the LGBTQ population that was able to effect an incredibly important behavior modifications to modify the environmental risk factors, those being the multi-partner sex parties, non-barrier associated intercourse, receptive and penetrative. And with that and the combination also of ring vaccination campaigns using the Jynneos smallpox and monkeypox vaccine, that the outbreak was brought to a very successful dull roar. There still are just very few sporadic cases reported, mostly in very population-dense parts of the country, so think large cities and intra-urban environments, and that's all well and good, but we've gotten away from case contact investigation and all of the associated ring vaccination strategies. So, as per the CDC, as we move into the summer, the next year, the next 5 years, the next 10 years, every single step of the way will emerge a new population of individuals who fit a risk pattern, a risk profile, who have not been vaccinated or not exposed to the Mpox virus and are now becoming sexually active. And as those new individuals emerge into society, then of course there's the risk that Mpox will again gain a toehold, perhaps again through a high-risk encounter, and create again a cluster of cases. The benefit of this, and I think the reason CDC is so publicly announcing the potential resurgence, is to retain, maintain, and support ongoing awareness among the at-risk populations that Mpox is not gone, it is out there, and is potential to come back. So that's among a population which by and large does not affect the pediatric population, so yay, great, wonderful, fantastic. However, any new resurgence of cases in the community has potential to create secondary cases among our pediatric population. So hard to predict, what might happen this summer or in the next year or the next 5 years or so. I think it is very likely there will be ongoing sporadic, very focused outbreaks or clusters, I should say, of cases. But my anticipation is that Mpox has been marked by every health department, county, state, regional in the country for a major cause of concern, and thus screening strategies are ongoing very actively. What can we do as reporting physicians and healthcare providers is to, if we have a suspect case of Mpox disease, the first step, again, should be to communicate with your local county health department with that suspect case so that they can, A, participate in working on the diagnosis, B, if confirmed, create and then perform a very close contact investigation, and C, provide support, treatment, vaccination, and testing if necessary to you, your practice, and patients. So as before, in the height of the Mpox outbreak, we just need to be ourselves conscious and aware of what Mpox looks like, and that's an easy search. Again, a pox is a pox is a pox. They look hemorrhagic. They're raised. They can be anywhere, including palms and soles, unfortunately. And fortunately, there can be a fairly decent overlap in the appearance of Coxsackie virus associated hand, foot, and mouth syndrome. So obviously, we are going to be seeing kiddos with palms and soles lesions that look somewhat pox-like. So I encourage you to go to the cdc.gov website or the AAP for that matter and print out the very grody pictures which are available there of Mpox pox lesions, so that you can compare and contrast to babies or children or teens who come into your practice, urgent care, hospital, emergency department, etc., with a suspect or a possible case. Have a low threshold to contact health department and or your friendly infectious disease provider with any concerns or questions about that possibility. That's what we can do to hopefully recognize and limit any local cases before they become a new major resurgence or outbreak. So those are the questions for this week. What else is out there? Boy, you'll note the last couple podcasts, we have not really talked a lot about our dear friend COVID-19 and SARS-CoV-2. That is also a virus which is not gone yet, just resting. We are still having sporadic cases, mostly among the adult population, but occasional pediatric cases as well, with one of the current circulating Omicron subvariants. The Kraken is one of them, the XBB.1.15s and 16s, which had emerged in, again, the country of India, are accounting for 3 to 5% and perhaps more of new isolates or new cases here in the States, and that affects Arizona as well. However, at least for the time being, the COVID-19 cases are a very sporadic experience, and that's a good thing. We're waiting to see what may happen with our next respiratory viral season, and if we're starting to return to normal patterns, meaning seeing RSV when we're supposed to see RSV in the late fall and winter months, similarly with our influenzas, adenoviruses, etc. We'll say, at least at the hospital and the communities which I cover, we're still seeing a fair amount of really aggressive adenovirus disease causing upper and lower respiratory tract disease, pink eye, cystitis, prolonged fevers, etc. So if, as with many of our providers here in Pima County, you are seeing children, young adults even, as well as infants, coming to you with fever for more than 5 or 7 days, do think adenovirus along with the other fun possibilities, and if possible to screen for those with the respiratory panel, consider doing so. Other things, we're continuing to see other community-acquired pneumonias out there. Certainly a decent cluster of viral gastroenteritis, with a little sprinkling here and there of bacterial enteritis, especially Shigella and Campylobacter, with known and typical risk factors, i.e. picnic-associated, playing with chickens, etc., and so forth. So no major trends right now, except potentially to note the adenovirus, which is out there. So, as always, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona chapter of the AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. In the meantime, keep those questions coming. Anything and everything is on the table. I will do my best to answer the questions as they come through and offer some insight. And as always, take care of yourselves. Pay attention to each other. Mental health is a big thing. Wellness is a big thing. And we all do better when we all do better. So ask your friends, your neighbors, your colleagues, your nursing staff, everybody else, how they're doing, and listen. And thank you all for listening to me. Have a great rest of week.